This is the technique I'm showing you is the posterior lateral glide for the shoulder joint. This is the technique you will use for pain management of the shoulder joint. No matter whether it is supraspinatus tendinitis, infraspinatus tendinitis, subscapular muscle involvement, bicipital tendinitis, or all the rotators involved, or the impingement or the subacromial bursitis, this technique works beautifully because this helps in correcting the faulty biomechanics of the glenohumeral joint. As we have already discussed in positional fault theory, head of the humerus is sitting slightly forward, those who are having pain. So altering the biomechanics of the rotators around the shoulder. And moment you put the head of the humerus back into its place, all the muscles are in optimal length and the pain goes off like that. And this was the technique we used for real-time ultrasonic to check if the glide is sustained or not during active movement versus passive movement. We have tried this technique on so many number of patients, and you will hardly see any patient who has not responded to this technique. So it's a posterior lateral glide. So one hand you are stabilizing on the scapula, while the other hand you will be putting on the medial side of the head of the humerus. Don't put it in front, that will cause pain to the patient. I'll put on the medial side. That is almost in front of the coracoid process. So I'm going to put heel of my hand there. The cup of my palm will come on front of the head of the humerus and the heel will come on the medial side like that. And the fingers will rest on the deltoid muscle. And the other hand which will come behind the scapula to stabilize it. Now stabilization means this is not the stabilization I'm talking about between the scapula and the thoracic cage. This is a relative stabilization I'm talking about between the scapula and the humerus. That means if the person is going above 90 degree and his scapula wants to rotate, I will allow it to rotate along with humerus. Otherwise, you will not be able to go into end range of flexion. So it is a relative movement between the glenoid fossa and the head of the humerus I am talking about. So one hand goes behind the scapula and the other hand goes there. And then you can do the passive accessory movement if you want, and that again works beautifully. But if you want to sustain the glide and move the arm passively, that is the best one I'll prefer for this particular technique. So you will need one more therapist always to help you performing the offending movement, and you give the glide to make it pain-free. So could you please come there? And of course you have to tell the patient in advance. First you have to give the glide and ask patient, is that comfortable to you?
Yes.
If the patient says yes, it is comfortable, then the second therapist move it passively into full abduction. Is that okay?
Yes.
Is that okay?
Yes.
Okay, take it down now. See how I am moving my arm. I am moving my arm along with the patient in order to sustain my glide. So I'm pushing it from this side and pushing it in that direction posterior laterally. Okay, so see my angle of my forearm. It is automatically going into posterior lateral direction. And see the angle of my forearm here. It is pushing it in this direction. So sustaining my glide and then asking the patient, is that fine? Is that okay?
Yes.
Is that okay?
Yes.
Okay, give the passive pressure, and if it is working better, okay, now keep doing in the end range only. Go back, now again, and back, and again. Now if it is the flexion which is restricted, and obviously now you will be doing flexion, you have to perform the offending movement. Again, you will need help of another therapist to perform the offending movement. Ask my model to rotate so you can see my front hand moving nicely. Stabilize, and then I give the glide there, sustain the glide, and then ask another therapist to perform the offending movement. Is that comfortable?
Yes.
If it is comfortable, go back to neutral again and do it again, and you reconfirm. And if it is working, work in available end range now. Okay. Now, in case it is horizontal adduction, abduction which is causing pain to the patient, so obviously you will be performing horizontal adduction and abduction. So you stabilize the scapula and give the same glide. If your hand is here, this will cause pain to the patient. Make sure you're not there in the front of the humerus. You're on the medial side of the humerus. So give the glide and then, so you perform the offending movement, horizontal abduction and adduction. Please note, it is the adduction which is causing pain to the patient. So I'm trying to achieve horizontal adduction and helping the patient. So in this technique, again, you have to remember that common mistakes are, if you're doing this movement, this is not acceptable. Now it's a movement between scapula and the thoracic cage. So you have to stabilize it. After a good stabilization only you get a good mobilization. So that's the movement, not this. And if you concentrate here, you will see the glide coming. Can you appreciate the movement there? So that's the glide. But now that's not the glide. So make sure you do the appropriate movement, placing your hand appropriately, doing the offending movement in a pain-free way. Like for the other technique, I said you should not be doing after arthroplasty, but this technique can be done after arthroplasty with care. In case you are a young budding physio, make sure you do it under the supervision of an experienced physiotherapist. And also, talk to your operating surgeon before doing any mobilization after arthroplasty of the shoulder joint. This technique will be very useful after any other surgery, like for the rotator cuff repair, after the repair for the Bankart lesion or the labrum tear or any other shoulder joint surgery. This technique you can do with care and this will give beautiful results. In case you have already gained range of motion, but shoulder joint is still giving pain, so this is the technique will help in removing that pain. And as I already said, all those indications, supraspinatus tendinitis, infraspinatus tendinitis, bicipital tendinitis, bursitis, impingement, painful arc syndrome, this technique works beautifully if delivered correctly. And make sure along with this technique, you shall be giving strengthening exercise to the rotators. Again, do not overtreat your patient. Just 6 to 10 oscillations into 3 sets are enough. Or in case you are doing the passive movements along with sustained glide, just do 6 to 10 movement into 3 sets. All the best.